So for patients that, get chemo, then they're on maintenance, atezo, and they progress, Josh, what do? Do you give them ipi-nivo?
Not if they're progressing on atezolizumab. That feels I don't do that. I hope for a clinical trials. What I do, our options are really bad right now. I think that we're left with, topotecan is the standard of care, which I don't think any of us really like using. We'll sometimes use irinotecan, I'll use a taxane, but the truth is we don't have a good option after progression on chemoimmunotherapy for extensive stage small cell lung cancer. If somebody has had progression after the 6 months off of chemotherapy, I would do platinum re-exposure with platinum etoposide or platinum irinotecan, depending upon various features. But we don't have good options there. It's a space where we really need good research. There's some drugs that are emerging, such as lurbinectedin, but that's where we are.
Jacob, so nice data from your group around temozolomide and PARP inhibitor combinations. Is that something you use, or what do you think?
Well, I mean, to be clear, that's Anna Farrago out of MGH is leading that. And I'll say, I mean, some patients tend to do really well on this, and it's generally very well tolerated. Cytopenias can be an issue. Occasionally fatigue can be an issue. That's really something for clinical trial, utilizing that. But we'll see where that data pans out ultimately. It's been promising. I know that was presented on an ASCO poster a couple years ago, 40% response rate and generally well tolerated. In this scenario, that's very compelling. So hopefully that pans out further.
And Leora, I think lurbinectedin is supposed to be, I think, reviewed by the FDA at some point this year. Do you have any experience with that?
I don't. I've been watching the data and it's interesting. I think we need to wait for the phase 3 because we see a lot of positive phase 2 data, and then the phase 3 trials come out and they're not quite as exciting. The phase 3 also incorporated adriamycin into therapy, which is not a drug that I like to use in this group of patients because of their cardiotoxic disease, but it would be nice to have a new second-line option. Paclitaxel has always been my go-to regimen.
So I do have some experience, and I think this is a drug that's generally been very well tolerated. And again, we're seeing response rates that are in the compelling range, initially around 40%. The more recent data is more in the 30s, but response rates that are compelling and a generally well tolerated drug. It is interesting. I agree that adriamycin is not a drug I'm excited to use, but to say that the side effect profile has been good enough that you can pair it with adriamycin. Interestingly, that trial is randomized to topotecan versus CAV, or you can choose either topotecan or CAV in a patient who gets randomized to the control arm. And in the very beginning of that trial, oncologists were utilizing topotecan, and then I guess remembered why they don't like topotecan, and then we saw more increase in people utilizing CAV as the control arm in that group, which it just makes the point that we just don't have a very good next line approved option. And so for a drug that's well tolerated, to have response rates in the 30s or even up to 40% is very compelling. And so I do think the data on this is fairly impressive, although I agree there's not yet a lot of it. So we'll see what happens.
It'll also be important to remember that the phase 3 data, when it does come out, is in the patients who got chemo. That was prior to the patients getting chemo checkpoint inhibitor combinations.
That's right. The other thing I'll say, though, for lurbinectedin is that in the single arm lurbinectedin is that it really showed some nice responses, even in those who had early progression of disease and after platinum etoposide. That has been a really resistant population that's very hard to treat. Now, those who had longer durations of response, so more than 6 months out of control after platinum etoposide, getting lurbinectedin did better than those with the early resistance to platinum etoposide getting lurbinectedin. But in both groups, we see responses to therapy. So it is a compelling option, and we'll see as the data comes out.
Thanks to everyone for really an excellent, lively, informative discussion. Before we conclude, I'd like to get final thoughts from each of you. You can be what you're excited about that's going to be coming up in the near future, or anything you want to sort of chat about as a final thought. Josh.
I think this is a very exciting time to be doing research in lung cancer. There have been so many wonderful advances which we've been able to talk about today, but there's so much more work to be done, both in the immunotherapy space, where I think we really need to identify a biomarker, and in the targeted therapy space, where we need to manage resistance. So I think a lot of work still to be done.
Leora.
Yeah, it's an exciting time to be in lung cancer with all the new agents that are approved. I think what I'm looking forward to seeing in the next few years is what's going to happen in early stage disease. I feel like we've made a lot of progress in late stage disease, but the majority of our patients with early stage disease still recur. And so will checkpoint inhibitors or targeted therapies in the adjuvant or neoadjuvant setting increase our chance of curing more of our early stage patients.
Tim.
Yeah, I think a lot of kudos is deserved by the medical oncology community for making me a sideline player for a lot of places where I used to have to give whole brain radiation for people we now know don't need that for molecular driven tumors. That said, it's also a great time to be a radiation oncologist in the lung cancer setting and give immune priming radiation to help improve the response for systemic treatment. So keep your local radiation oncologist in mind as a partner.
And Jacob.
Yeah, this is an exciting time with lung cancer treatments. It's only been about 10 years since initially starting in the clinics treating people with EGFR TKI for the first targeted therapies. Since then, we now have an array of targets, an array of drugs, some in multiple cases, multiple drugs for single targets. So there's a lot that's gone on with immunotherapy now that is benefiting our patients also. There's a lot happening. One thing going to what Leora Horn said about early stage disease, and a topic not really covered within this talk, and a big topic in itself, is lung screening. With lung screening, we're really able to detect cancers at much more commonly at an earlier stage, at which point this is more curable. And I think the potential benefits of lung screening really may outweigh any one of these things that we've talked about once it's more widely done.
Okay, thank you all very much, and to our viewing audience as well. We hope you found this OncLive peer exchange discussion to be useful and informative. Thank you.